Good morning, everybody. So, what all topics we have covered till now? It's, I think almost a month I have not come for the lecture. So, what all topics you have covered? Any queries that you want to ask? या सब कुछ आता ही है हमको ना. Last was lecture on fungal infections, viral infections. किसको पता है ना कोई तो fungal infections का it was covered completely or still half of it is remaining completed. So today let us take a lecture on leprosy. It's a very important topic. So leprosy is a common presentation still in India. So whenever we enter dermatology, we have a degree in leprology also. So usually in Rajasthan and many places we have three topics to cover in dermatology, that is dermatology, venereology and leprology. So three things, you get a MD in all these three subjects. So it's a very important topic that we'll try to cover today. It's almost 15 minutes, more than 15 minutes. What exactly is leprosy? यहाँ बताओ, कोई एग्जाम नहीं हो रहा है, गलत बोलोगे तो भी चलेगा. 45 मिनट्स में कुछ ना कुछ हमको लेके जाना है यहाँ से ना, जो भी याद रहे थोड़ा बहुत ना, एटलीस्ट आपको पता हो. लेप्रोसी was endemic in India. The number is decreasing nowadays, but still we find many cases, and at few places there is resurgence of leprosy at many places now. So many programs are being run by the government of India to contain leprosy. We don't have much of deformities nowadays, but the incidence of leprosy is still there. So what is leprosy? Another name for leprosy is Hansen's disease. So usually on prescriptions we are writing Hansen's disease so that the patient is not embarrassed, and that prescription, if it goes to other places, they are not able to know what exactly he is suffering from. But the patient should know that he is having leprosy, he has to take treatment for a very long period. So counseling is very important in cases of leprosy. Once you counsel, they may spread leprosy to other individuals also in the family. So counseling is important so that they take the treatment properly for a year at least. So what is leprosy? What is the causative organism of leprosy? कुछ तो पता होगा. leprosy तो सुनते आ रहे हो बचपन से ना. क्या होता है, किससे होती है? माइकोबैक्टीरियम लेप्रे. क्या क्या इसमें क्लिनिकल फाइंडिंग्स होती हैं, कुछ आपको पता है? क्या होता है? मल्टीपल स्किन लीजन्स, न्यूरोपैथी. या न्यूरोपैथी इज इम्पॉर्टेंट. देयर इज लॉस ऑफ सेंसेशन in cases, and it is caused by Mycobacterium leprae. So this is good enough to start with. So we'll cover all these topics during the lecture. So it's a long list of topics to be done. So coming to the history of leprosy, so it's a chronic systemic disease. It's not a just cutaneous disease, it's also systemic disease. Many organs are infected or affected by the lepra bacilli. It is caused by Mycobacterium leprae, manifested as development of specific granulomatous or neuropathic lesions. So granuloma formation is there, and neurotropic lesions means it leads to affection of the nerves, which leads to various manifestations of leprosy. Lesions in the skin, mucous membrane, eyes, nerves, bones and viscera. So it's not just a skin disease, it's a systemic disease as well. So oldest infection known to mankind, and the synonyms are Hansen's disease, which is the most used term nowadays, and our Indian system calls it as Kusht Rog. So Kusht Rog was, as everybody know, it was known by the name of Kusht Rog. Transmission of leprosy. So transmission of leprosy, everybody knows, it through respiratory route. This is the commonest route which leads to transmission of the lepra bacilli. Inhalation of the bacilli-laden droplets is the commonest. Other mode of transmission is cutaneous, that is touch or skin to skin contact. So these two important transmission modes are there. One is through the droplet infections, that is through inhalation, other is skin to skin contacts. Other that have been documented are GIT spread or the intradermal spreads, which are not yet proven. Epidemiology includes it occurs in all the age groups and peak ages between 10 to 20 years. This is the age when you get infected. Maybe you will not get the signs and symptoms of leprosy. So it's a very long incubation period in cases of leprosy. What is incubation period? Incubation period क्या है? Excuse me. जोर से बोलो आप. Yeah. So it's the period between infection, first entry of the organism, and the coming of signs and symptoms. So in leprosy, it's a huge incubation period. It is from 1 year to 40 years. Some patients they get leprosy after 40 years. So it's a long incubation period. It's not fixed as other infections that we see, viral and bacterial infections. So usually we see that patients they get infected in between the age group of 10 to 20. They manifest also. They may manifest also. They may not also. So males are much commonly infected than the females, and children are most susceptible. Immune status is very important. So those are infected whose immune status is compromised, or immune status against leprobacilli is very less. Overcrowding is one of the features. That's why it's found much more common in the lower socioeconomic people. Low socioeconomic status is a common epidemiological factor which leads to transmission of this bacteria. So these are the Indian figures, very old figures are there. So immunity and leprosy, this is the most important topic. So we see leprosy in day-to-day practice, but not all are affected, or not all in the family are affected. So if the immunity, host immunity is excellent, he or she will have no infection at all. Good immunity may have subclinical infection. Fair may lead to indeterminate, pure neuritic and tuberculoid leprosy. So these are the types of leprosy we'll discuss. There are many classifications of leprosy. We'll just discuss the subtle one or the easiest one. Poor immunity may lead to higher grades of leprosy, which include mid-borderline, borderline lepromatous, and very poor immunity to the mycobacterium may lead to the lepromatous leprosy. This is the highest grade of leprosy with least resistance and many signs and symptoms in cases of lepromatous leprosy. So this diagram shows how the leprobacilli enters and what is the outcome, final outcome in cases of those who are exposed to the leprobacilli. So in healthy individual, you'll find there is complete resistance to the bacteria and there is no infection at all. He remains healthy. But then comes the indeterminate phase in those whose immunity is not determined. So if it is less, it will go on the lepromatous pole. If it is high, they may go into the tuberculoid pole. So in tuberculoid leprosy, there is high resistance, and sometimes without treatment also patient may take care of his infection and again become a healthy person or healthy individual. The immunity takes care of the infection. And patients or people with some resistance, they have borderline leprosy, and those who are having lower resistance will lead to lepromatous leprosy. So what exactly is Mycobacterium lepra? It's an obligate intracellular acid-fast bacilli. This is very important. It's a intracellular bacilli. So you'll find the bacilli in the cells once you take a histopathology. Affinity for the skin, nerves and muscle tissue is most common. Found in macrophages, histiocytes and Schwann cells. So these are the cells where the bacilli, they are concentrated. Not cultivable, so they cannot be cultivated. Cultivated in the sense, if you want to diagnose, you cannot go for culture for this bacteria. There are other fungus and bacteria and virus which can be cultured, which can be shown on the slides, and we can go for culture and sensitivity. But in case of mycobacteria, we are not able to culture them. So they can be grown in animal models. It's not, we cannot culture in a artificial media, but they can be grown in certain animals, they can be grown. So these are in animal models, closely resemble Mycobacterium tuberculosis, but less acid-fast than Mycobacterial tuberculosis, and multiplies in 11 to 13 days. So it's a long time. It takes a long time to multiply as well. So this diagram represents the resistant part and the type of leprosy that the patient or the person will be affected with. So in cases we see the patients having least resistance will have lepromatous leprosy, and as the resistance of the patient increases, the other end of the pole is tuberculoid leprosy. So this is the common classification, broad classification for your concern. I think this is enough. There are many classifications classified according to the number of bacteria, according to the number of lesions. There are cases of reactions also in cases of leprosy. So this is the simplest classification, where lepromatous leprosy, other is borderline lepromatous, mid borderline, borderline tuberculoid, and tuberculoid pole. Now we'll just discuss each one of them in few slides. So tuberculoid pole is where the patient has the highest resistance. Single, so lesions are single or few, asymmetrical, well-defined erythematous or copper-colored. Sensations are absent because of the affection of nerves. Nerves are thickened, presence of feeding nerves, abscesses. Skin smears are negative. Skin smears are negative means the number of bacilli is very less because of the high resistance of the patient. Lepromin test is strongly positive because the immunity is still there in such patients in tuberculoid leprosy, so the lepromin test is strongly positive. This is opposite in case of lepromatous leprosy. Where on slides, if you make a slide in lepromatous leprosy, the skin smears are loaded with bacilli. Sometimes we call them globi. Globi means it's a group of bacilli grouped together in various cells, and lepromin test also is negative. Course is relatively benign and stable with good prognosis. So this is a case of tuberculoid leprosy. So you'll find the erythematous plaque is there. Many differential diagnoses will be there for this lesion. Single lesion if you find, then what all differential diagnosis you will put? इसमें आपको क्या लग रहा है जो अभी आपने 4-5 चैप्टर्स पढ़े हैं उसमें से? Tinea. So tinea is one of the commonest differential diagnosis on spot examination. It's a spotter. But what will be the differences? Lot of differences once you take history. क्या क्या हिस्ट्री में differences होंगे? Just you can ask them and you find out whether it is tinea or not. Sensations may be lost. सबसे पहले तो पेशेंट से पूछोगे ना, व्हाट आर द सिम्टम्स. पेशेंट सबसे पहले तो क्या बताएगा इन केसेस ऑफ टीनिया. सपोज इट्स अ केस ऑफ टीनिया, itching is most important. Patient in this case will not complain. He will just see the lesion and maybe he'll not come to you for a very long time. Once it's present for many months, then he'll come to you because the lesion is not disappearing. Whereas in case of tinea, a lot of itching is there, redness is there, scaling is there. So he'll come to you earlier than a case of leprosy. So itching is the most common complaint that the patient will have. Whereas in this case, it's asymptomatic. Scaling will be there, central clearance you can see in this lesion also. So it's a well-defined hypopigmented plaque with erythematous border. So this is the picture. Then comes the borderline leprosy. Borderline is in between tuberculoid and lepromatous pole. So just remember tuberculoid leprosy and lepromatous leprosy. In between is the borderline leprosy. Borderline tuberculoid, borderline lepromatous, and borderline in the middle one. Subdivided into BT, BB and BL. Course is unstable because it is borderline with variable prognosis, may progress to subpolar lepromatous. This may downgrade into lepromatous leprosy or upgrade into tuberculoid pole. Lepromin test is negative, weakly positive in BT. So this lepromin test depends upon our immunity. If immunity is strong, it will be positive, otherwise it will be negative. So lepromatous leprosy pole, it will be negative, whereas it will be positive in case of borderline tuberculoid. So borderline tuberculoid, the lesions start increasing. In tuberculoid pole, you will find single lesion, whereas in borderline lepromatous, you will find few asymmetric, hypopigmented skin-colored plaques with ill-defined margins. Presence of satellite lesions, sensory impairment is marked, nerve involvement is marked and asymmetrical. So these are the pictures showing tuberculoid. So we'll give stress more to the pictures than the write-up. So just remember, You should know the basics of leprosy, when to suspect a case of leprosy, because it's very important. You should not miss a case of leprosy. So at least you can, if you are not able to diagnose the various poles, at least you should have suspicion that it's a case of leprosy, and you can refer to a dermatologist as early as possible. So borderline tuberculoid, so these have multiple DDs. All of them have multiple DDs because the presentation is varied. So this is a case of borderline tuberculoid leprosy. So mid-borderline, borderline. So this is unstable form. Reactions are frequent. Annular lesions with characteristic punched out appearance. This is a characteristic appearance of a borderline, borderline leprosy, where the picture is of inverted saucer-shaped appearance is there. Sensory impairment is moderate and marked nerve involvement is marked. So this is a case where we'll find as if an inverted saucer appearance is there. Central clearance is there, and in the periphery you'll find a broad band of erythematous plaque. So annular erythematous plaque on an extensor aspect of left wrist, inverted saucer appearance. Then comes the borderline leprosy, borderline lepromatous leprosy. Again the number increases. Now it is much more than the tuberculoid pole. The number starts increasing much more because of the decrease of immunity. As the immunity decreases, the bacteria takes over and multiple lesions are there. So multiple shiny macules, papules, nodules, all sorts of lesions will be there. Sensory impairment is slight, nerve involvement is widespread and less asymmetric, and glove and stocking hypoanesthesia is there. So these are the lesions of borderline lepromatous leprosy. Multiple lesions over the body, symmetrical, hypopigmented, maybe plaque, maybe papule, maybe nodule, maybe hypopigmented lesions only. Then comes the lepromatous leprosy. Multiple hypopigmented, erythematous, coppery, shiny, macules, papules, so all sorts of lesions. The most important thing is that these are sensory loss is there. Otherwise, multiple lesions can be there in so many other conditions in dermatology. Lesions symmetrically distributed, small, multiple, shiny, normal, mild sensory loss. Leonine facies is there, so this may affect the face. Multiple nodules may erupt on the face, and face appears to be like a lion, what we call is leonine facies. Infiltration of skin with nodules, loss of eyebrows, eyelashes. So if you find a loss of eyebrows, think of leprosy. What other conditions shows loss of eyebrows? Eyebrow का loss और कहाँ कहाँ हो सकता है? Alopecia is one of the common in dermatology. So other आप तो ज़्यादा बाहर दूसरे ज़्यादा पढ़ते होंगे, dermatology तो कम पढ़ते हैं. What other conditions may come with loss of eyebrows, especially the lateral aspect of loss of eyebrows? So these are the cases of lepromatous leprosy, showing multiple nodules over the face. This seems to be like a lion, so it's what we call as leonine facies is there. Multiple papulonodules, infiltration over the face, whole of the face may. This is the infiltration of the ear. So leprosy bacilli as such cannot multiply in a hot region. So it always finds a colder place to multiply. So you'll find lesions over the ear pinna. This is the farthest of the region where it's little bit cold than the region around the trunk and limbs. So you'll find lesions over the eyebrows, over the ear lobules, over the face, over the extremities much more than the central part. Indeterminate leprosy, where the lepra bacilli is not able to determine because of the changes in the immunity. So there are many types of lesions. Usually lesions are few. So this is a case of indeterminate leprosy. You will find an ill-defined hypopigmented patch over the left cheek. So just a hypopigmented patch over the left cheek may present as an indeterminate leprosy. What are the differential of this case? Face पे hypopigmented patch is there. ये सब कर चुके हैं हम लोग ना. We already gone through this. That's why I am asking about the differential diagnosis in this case. Vitiligo is one of them. Hypopigmentation, it may start as a vitiligo. It may be pityriasis alba. So these are few common differential diagnoses in a child. But then you should have a on the back of the mind there should be a diagnosis of indeterminate leprosy also, that you should not miss. So how you will do that? You may go for the sensations over the lesions. If they are compromised, you should think of indeterminate leprosy. Pure neuritic leprosy, that means the lesions are not there over the skin, only nerve is involved. So neuritic manifestations like tingling, heaviness, numbness, paresthesis, hypotonia, atrophy, claw, hand and toes, wrist drop, foot drop. So many varied presentation, but there are no skin lesions as such. And other changes may be anhydrotic, dry, glossy skin because of the involvement of the sweat glands. There is decrease in the sweating in such cases, which leads to dryness. So in a patient of leprosy, you will find much more dryness. Blisters are due to why there is blistering in a case of leprosy. So blistering is because of the neuropathy. So as such, sensations are not there. Patient is not able to, if he catch holds of a hot cup, he or she doesn't, he or she doesn't get the sensation of hot and cold. So the hand is burnt and it may lead to blister formation because of the loss of sensation. So blistering is much more common, especially over the hands and feet. Then this may lead to neuropathic ulceration also. The cause of neuropathic ulceration is also the same. Because of the loss of sensation, there is chronic trauma, and chronic trauma leads to ulceration, which again doesn't heal because of the recurrent trauma. Decalcification, bone resorption. Pure neuritic leprosy is lepromatosis strongly positive, course is spontaneous regression, silent neuritis, silent neuropathy. So this is a pure neuritic leprosy. You will find the enlargement or of the nerve. So note the thickening of the ulnar nerve. Ulnar nerve is thickened, but as such the skin lesions are not there. Nerve involvement in leprosy is very important, which leads to sensory impairment. Sensory involvement leads to anesthesia in hands and feet. Glove and stocking anesthesia. What is glove and stocking anesthesia? The name suggests. In dermatology, you will see most of the name will suggest what they are talking about. So glove, whatever gloves you are wearing, the anesthesia is till this region. Same as stockings also will get anesthesia till the region of the stockings that you are wearing. Motor involvement leads to wasting and paralysis of the muscle, and autonomic involvement leads to ichthyosis. Ichthyosis is due to less of sweat. Sweating is also decreased because of the nerve involvement. So autonomic nervous system will lead to decrease in sweating and ultimately leads to dryness and ichthyosis. Loss of hair and sweating. So other features, as it's not just a skin disease, it's a systemic disease as well. So you will get nasal stuffiness, crusting, epistaxis, hoarseness of voice, gynecomastia, saddle nose, bone resorption and disability. Now the differential diagnosis, a lot of differential diagnosis because we get so many types of cases in leprosy, all types of cases, macules, papules, nodules, plaques, annular lesions. We will not go into differential diagnosis in each and every case. So these are the pictures. We will just go through the pictures only. So we will get a similar lesion in leprosy also. So there are varied diagnoses. These are cases not of leprosy but of different diseases. This is the case of, ये आपका हो चुके हैं सारे ना, ये क्या है? डिफरेंशियल बता दो if not able to diagnose. ये बोला किसी ने? Tinea versicolor. This is the case of tinea versicolor. So you can, in such cases also, which is a benign infection as such, may be a case of leprosy also. So just at the back of the mind, the differential diagnosis should be there. Differential diagnosis of leprosy in a hypopigmented patches over the trunk and hypopigmented. So these are PKDL, will not go into this. Infiltrated lesions. So these are other cases where you will get similar picture as the case of leprosy. Here also you will find edematous papular nodule. This is a case of lupus over the face. We can again diagnose as a case of borderline lepromatous leprosy. And PKDLA, PKDLA क्या चीज़ है? बोलो गलत होगा और क्या? Post calaza dermal leishmaniasis. So differential diagnosis, again nodular lesion. So it's a differential diagnosis, all sorts of lesions. So it covers whole of dermatology if you just read leprosy. This is a case of neurofibromatosis. Multiple neurofibromas, and this bigger hyperpigmented patch is. Have you seen a case of neurofibromatosis or read about it? No. These are multiple neurofibromas, scapulae macules are there. Again neurofibromatosis. Multiple papular nodules are there. These are all neurofibromas in the case of neurofibromatosis. It's a genetic disorder. You will get to see many cases when you come to your postings in dermatology. I think nobody is coming for the postings of dermatology. आप आए हो कभी dermatology? आपकी 15 दिन की पोस्टिंग होती है, अभी आई नहीं आपकी पोस्टिंग? सेकेंड ईयर वाले आ रहे हैं, आप थर्ड ईयर में हो ना? कौन सी ईयर में हो आप लोग? थर्ड ईयर ना, सेकेंड ईयर की हो गई और थर्ड ईयर की नहीं पोस्टिंग, वापस है सेकेंड पोस्टिंग है आपकी, तो कुछ तो आता होगा सब कुछ आपको। कोविड के कारण हुआ नहीं था आपका पोस्टिंग, दैट वाज अ ग्रेट लॉस। एक बार भी पोस्टिंग नहीं हुई अभी तक आपकी ना, इस बार आना रेगुलरली आप, ठीक है ना, कम रेगुलरली टू सी पेशेंट्स इन डर्मेटोलॉजी, क्योंकि अभी मे बी अदर सब्जेक्ट्स आर मच मोर इम्पॉर्टेंट टू यू, बट जब पीजी लेने जाओगे देन दिस विल बी योर सब्जेक्ट ऑफ इंटरेस्ट। सो थोड़ा बहुत देख लो उसको है क्या डर्मेटोलॉजी में। सो न्यूरोलॉजिकल कंडीशंस, अगेन देयर इज अ लॉन्ग लिस्ट, विल नॉट डिस्कस peripheral neuropathy, diabetic neuropathy, this is all. Now coming to diagnosis, how to diagnose a case of leprosy. You saw various presentations of leprosy. It can be of any sort of skin lesion, but the most important thing is loss of sensation. If you find a loss of sensation in a case of skin disease, think of leprosy and then examine properly. So cardinal signs of leprosy are, first is sensory impairment in the affected area. So what we do for sensory impairment, how you know that patient is having sensory impairment? क्या करते हो उसमें, और क्या होगा? मूवमेंट से क्या? मूवमेंट कम्स विथ मस्कुलर लॉस, मोटर न्यूरोपैथी होगा तब होगा। सेंसेशंस लॉस में सेंसरी लॉस इज देयर, पेशेंट खुद बताएगा आपको कि यहाँ मुझे पता नहीं लगता है। इफ इट इज अ लार्ज पैच, पेशेंट विल टेल कि यहाँ मुझे कुछ फील नहीं हो रहा है। दिस इज द कंप्लेंट फ्रॉम द पेशेंट। फॉर यू विल डू वेरियस टेस्ट. What we do is prick, we'll just prick to find the pain sensation. We'll just, with a swab of cotton, we just touch in and feel whether the patient is having the touch sensation. And the most important, the first one to go is the loss of temperature. Patient is not able to feel the temperature. So we'll take the test tubes with hot and cold water and we touch the patient. If he or she feels whether it is hot or cold, she is able to differentiate between these two. If not, then touch sensation is gone. So it's not that all three are gone in all the patients. First one to go is the temperature, and then the touch sensation, and prick is the last one to go. Pain तो आप जोर से सुई चुबाओगे तो कुछ ना कुछ तो उसको फील होगा, but then that is also lost in few cases. Second is enlargement of peripheral nerves associated with signs of peripheral nerve damage. Now comes the nerve involvement. The peripheral nerves are involved. Why peripheral nerves are involved? Peripheral nerves are only involved mostly. First, and it's good for us also, we will be able to feel the peripheral nerves. Otherwise, if other nerves are involved, then we will not be able to make it out. But peripheral nerves क्यों involvement ज़्यादा होता है other nerves से? Nerves की affinity होती है. Why peripheral nerves? Because of the temperature. We already discussed. जितना बाहर होगा, temperature is cooler, they are able to multiply. जहाँ गर्मी होगी, they will not be able to multiply. जहाँ गर्म ज़्यादा होगा, internal temperature is maintained, वहाँ lepra bacilli multiply नहीं करते हैं. So you will find all the lesions also in the colder region. and peripheral neuropathy also in the lesions, peripheral nerves mostly. And you will find acid-fast bacilli in the lesion. If you make a slide from the lesion, if they are dividing, you will find the acid-fast bacilli. And this also you will be able to find in which cases? Not all cases you will find acid-fast bacilli on making a slit smear. कहाँ पे मिलेगा कहाँ पे नहीं मिलेगा in different types of leprosy. बताओ. Where there are more chances of getting the leprobacilli in the slide. Lepromatous pool, because the immunity is less, the bacteria are multiplying, and you will find much more. If number is more, you will be easily able to see the bacteria. They are in globi. Multiple globi can be seen in cases of lepromatous leprosy. Whereas tuberculoid, it's very difficult to see a leprobacilli because of good immunity and less of lesions. Clinical examination type and number of skin lesions, sensory impairment, you will see the sensations and see it glove and stocking anesthesia. Motor examination you will do. Then sweating you will see. Sweating is also impaired in cases of leprosy, and loss of hair is also there. Touch sensation, temperature sensation, pain sensation. Testing of motor is done through clinically, you have to do that. Electrodiagnosis is employed. Early by electrical stimulation, will not go deep into it. So these are the nerves that we palpate, we are able to palpate because of their peripheral nature. The examination of nerves in leprosy, we are able to palpate the ulnar nerve. It's not that once you get the ulnar nerve, it is a case of leprosy. So ulnar nerve is palpable in a normal individual also. You have to just see the differences between the two ulnar nerves, whether it is enlarged, one is enlarged, whether it is thick, edematous, painful, so many other things that you have to go through. Radial cutaneous nerve, lateral popliteal nerve, sural nerve. Sural nerve is the nerve where we take a skin biopsy or the nerve biopsy, to be more specific. So if you want to see the changes in the nerve, we take the sural biopsy, sural nerve biopsy. Superficial peroneal and posterior tubal nerves. So this is a case of enlargement of the greater auricular nerve. So it's visible once you tilt the face to one side. So it's a long cord-like nerve you can see, which is usually not visible in a normal person. Then we'll go for bacteriological examination. This is what we do is slit smear. We'll just slit the skin, we'll prepare a slide and we'll stain it for acid-fast bacilli. So make a slit, scrape the base and you'll stain it with Gill-Nielsen stain to find the AB bacilli. Reading of smear under bacteriological index, morphological index will not go into it. Then histopathological examination can find bacilli if you stain with AB stain. Nerve biopsy, sweat function test, lepromin test, and animal models. So these are the animals where you can grow the bacteria. You cannot grow in an artificial environment. So armadillo, usually 9-banded armadillo is there, which are used for the research purposes. So know the resistance of the drug or the effect of the drug. We propagate the bacteria in armadillo. Other is nude mice and Korean chipmunk. So this is. So other investigations are the serological assays, PCR, other techniques are nowadays used, but mostly the diagnosis is clinical. And slit smear is enough to diagnose, and other, if you are still suspicious, you can go for histopathology. Then there are two regimes of the treatment. Coming to the treatment part, it's may be difficult to diagnose, but very easy to treat. Not much regimens are there. We have divided into paucibacillary and multibacillary leprosy. The paucibacillary leprosy includes the tuberculoid leprosy and the borderline tuberculoid, where lesions are less than 5. So we give paucibacillary leprosy, a paucibacillary pack, which includes rifampicin, which is given 600 mg stat. So this has to be given in front of you. So you have to give to the patient 600 mg stat. This 600 mg stat kills almost 90% of the bacteria. Then dapsone is given daily for 1 month, and this we have a blister packs with us, which is free from Government of India and WHO. This is given to the patient free every month. He has to come for examination every month. and we give either of the two, whether it's either the paucibacillary or the multibacillary packs to the patient. The multibacillary has to be given for 1 year. So this is the new regimen. Before it was given for 2 years. Nowadays in paucibacillary leprosy we give treatment for 6 months, and in multibacillary we give treatment for 1 year. The multibacillary includes rifampicin, clofazimine, and dapsone 100. This is given supervised, and then patient has to take dapsone 100 milligram and clofazimine 50 milligram daily for a month. So blister packs for MDT. Easy to use, handy, and convenient size, and patient is able to know how many days he has taken the treatment. It's a blister pack with 30 days. Provide complete treatment. So as if it's similar to the OC pills. So days are written and number is written. Similarly, we get these packs so the patient doesn't miss even for a single day. Improves clinical attendance. He has to come every month to take the treatment. Drugs are better protected against moisture, ensure quick dispense of the drug can be dispensed. So these are the blisters that we have in our department. So why there are 4 blisters each? For children it's different. The dose is different for children. So we have paucibacillary, multibacillary for children, paucibacillary, multibacillary for the adults. So this is MDT MD, MDT PB, MDT PB child, and MDT PB for the child. Other regimes are there, will not discuss. Even if you remember the original regimen is more than enough. Newer drugs will not go into it. Coming to the deformities, so there are 2 types of deformities. If the leprosy is not treated properly, if patient is not taking treatment, this may lead to deformities in the case of leprosy. So we have seen all pictures of deformities that this is the case of leprosy. Usually nowadays we are seeing less of deformities because patient is getting free treatment, they are concerned, awareness is there, and patients are taking regular treatment. So primary and the secondary one. Primary are caused by tissue reaction to the infection with M. leprae. So leonine facies is the primary deformity. Flat nose, claw hand, these are directly involvement because of the direct involvement of the bacillus. Secondary occurs as a result of damage to the anesthetic part of the body that we saw, the neuropathic ulceration and blister formation. These are secondary deformities or complications. Plantar ulceration and corneal ulcerations. Primary deformities, leonine facies, loss of eyebrows and eyelashes. This you will find in alopecia areata also, you will find in hypothyroidism also. Then depressed nose, gynecomastia and palatal perforations are there. So this is the case of facial deformity and showing a case with leonine facies. Depressed, sagging of the nose is there. Secondary is corneal ulceration, plantar ulceration, resorption and Charcot joint. So this depicts the case of leprosy. This was usually the picture before. Nowadays we are not able to see such pictures because patients are getting proper treatment on time. So this was the complication without treatment. There was resorption of the fingers. Then nerve deformities leads to claw hand because of the involvement of ulnar nerve and medial nerve. Clawing of the toes, wrist drop, foot drop, leg of thumb. So this is clawing of the hand. This is claw hand. So you are not able to straighten the fingers. If you straighten the finger again, if you leave, it will come back to the same position. This is what we call it claw hand because of the ulnar nerve involvement. Trophic stages are ulceration because of the neuropathy. These are trophic ulceration, wherever the pressure is more and sensations are not there. So you will find ulceration over the feet. These are not infected as such. This is just because of the neuropathy. So this is a deep trophic ulceration because of the neuropathy, loss of sensation. Prevention of deformities, early detection of nerve damage, adequate treatment of leprosy patients, use of protective footwear, adequate hydration of skin and physiotherapy, management of deformities, reconstructive surgery and rehabilitation. The prevention and control of leprosy, prevention of leprosy, early detection through survey initiation of treatment, and control of leprosy is by case detection, case holding through regular clinical examination every month, giving of the MDT packs to the patient, and health education of the public and patients at large. So various organizations are working to eradicate leprosy. Our organization, Indian organization, National Leprosy Control Program is going on, and nowadays we are having National Leprosy Eradication Program. National Leprosy Eradication Program, rehabilitation of the leprosy. That's it. So this is in brief. There are around 250 slides, but I've taken out 50-60 slides only that we have discussed. So this is, I think, if you know this much, is much more enough. It's more than enough. So any questions in leprosy? Anything you are not able to understand, or आ गया सब कुछ? At least you will have the discrimination that whether it's a case of leprosy or a common skin disease. This is most important. Just sensations are most important, because otherwise, if delay is there, it may lead to deformities, which are very difficult to treat. So such a patient should be diagnosed at the earliest, treated properly for 6 months or 1 year as described, and followed up regularly so that other family members of the patients are not affected. Thank you.